All right, welcome back. And we will be looking at blood pressure regulatory mechanisms now. Okay. What regulates blood pressure? Now, there are mechanisms that will regulate blood pressure on a very regular basis. So on short-term basis, from minute to minute, second to second. Yeah. So these are the neural cardiovascular reflexes: baroreceptor reflex, chemoreceptor reflex, and brain ischemic response. Then we have many hormones that can affect blood pressure. Yeah. And then we have kidneys that can affect blood pressure by increasing the blood volume or decreasing the blood volume. Okay, so they can affect blood pressure. Now, the reflexes, these are short term. They act rapidly. They respond very quickly. They act rapidly. Hormones are sometimes classified as intermediate, so it will take some time for them. So the hormone has to be released in circulation, reach the target tissue, and then have its effect. So it could take from minutes to hours for these hormones to take effect. Kidneys, or the body fluid control system, is long term, could take even days or weeks to set in. Okay? So any change in blood pressure will activate these responses. Let's look at them one by one now. Baroreceptors. So there are these receptors which are present in the carotid artery and the aortic arch. As the name tells you, baroreceptors. So what are they sensing? Barometer, pressure. They're sensing pressure, right? So if pressure drops in the aorta or in the carotid sinus, they will inform the nervous system. The central nervous system will then, depending upon what the signal is, if the pressure has increased, for example, the central nervous system will fire parasympathetic nervous system to bring the blood pressure down. Okay? If the pressure has dropped, then the nervous system will fire sympathetic signals to bring the pressure back to normal. Make sense? This is baroreceptors, and they work very quickly. These baroreceptors are always firing at a basal rate. So the brain, the higher centers are always aware of what the pressure is. When their firing rate changes, whether it decreases or increases, the CNS knows there is a change in pressure and the action is taken. Okay? Chemoreceptors are another type of receptors. As the name tells you, they determine or they detect chemical changes in the blood. What sort of chemical changes you think they'll be picking up? This one. So oxygen content in the blood, CO2 content in the blood, and pH of the blood. These three will stimulate chemoreceptors. If oxygenation is falling, okay, you need to increase your heart rate and blood pressure so that you supply more oxygen to the body cells. All right. So we'll go from the chemoreceptors to the this integration center, which is present in the brainstem, and it will then determine whether you need to fire the parasympathetic nervous system or you need to fire the sympathetic nervous system. Now, you would now ask, how is blood pressure related to this oxygen and CO2 and pH? Anyone? Baroreceptors makes sense. Pressure. We're talking about blood pressure. So baroreceptors will fire. What about chemoreceptors? Anyone? Any change in pressure, okay, will first stimulate baroreceptors, and they will fix it if they can. If they can't, and blood pressure, for example, keeps dropping and dropping and dropping, when it goes to a certain low level, that it even affects the oxygenation of blood, then chemoreceptors will set in. So that is at an extreme. Usually in a normal person, physiologically, it's the baroreceptor reflex which is working all the time and keeping the blood pressure constant. If that receptor fails, if that reflex fails, and blood pressure drops to really, really low levels, to the extent that the blood is not being oxygenated from the lungs and CO2 is being accumulated and pH is going up, pH is going down, then chemoreceptors will kick in. Okay? All right. Now, how these both receptors work, both chemo and baroreceptors? These receptors will send signal to the integrating center within the medulla oblongata, as I told you earlier. Okay, baroreceptors, chemoreceptors. Signal goes through these cranial nerves, and then you have either signal coming through the vagus nerve or through the sympathetic nervous system. Okay, so depending upon what the signal is, appropriate response will be created. Okay, so these effectors, the sympathetic and parasympathetic, will affect your cardiac muscle. They will affect blood vessels. Okay, there will be relief catecholamines from the medulla as well, and also, if you remember, renin-angiotensin aldosterone system. That is not the immediate system, but the sympathetic nerves can actually start the activation of RAA axis, which will take some time to kick in. Okay. At the same time, hypothalamus will release vasopressin, which will cause vasoconstriction, bring the blood pressure back to normal. So all these effects will take place. Out of these, the immediate response is on the cardiac muscle and on the blood vessels. So the diameter of blood vessels and the contractility of cardiac muscle. These are the immediate effects. Other effects will take some time. Okay, make sense? Now let's look at this hormonal axis now, renin-angiotensin aldosterone system. This comes under the intermediate, blood pressure regulatory mechanisms. Yeah. Okay. How many of you have studied this system before? Renin-angiotensin aldosterone. You have, yeah. Okay. Perfect. So I'll just go through quickly, and so it's going to be a recap of what you already know. Whenever there is a decrease in blood volume or blood pressure, kidneys will really, there is baroreceptor that is happening, right? Sympathetic tone increases. This also causes release of renin from these special cells in kidney. This decrease in blood volume and pressure directly also stimulates the cells to increase production of renin. Renin is an enzyme which converts angiotensinogen to angiotensin 1 in the blood. Okay, this one came from liver. It is converted to angiotensin 1, which then gets converted to angiotensin 2 via this enzyme, angiotensin converting enzyme. This enzyme is produced by cells in the lungs. Okay, when this is produced, angiotensin 2, it has multiple effects. Okay, it causes vascular effects and also volume effects. So it causes vasoconstriction. When you cause vasoconstriction, what happens? Total peripheral resistance increases. So blood pressure will increase. Remember? It also has volume effects. It will go and stimulate adrenal gland to produce aldosterone. Aldosterone will cause sodium and water retention in the body. Blood volume will increase. Blood pressure will increase. Make sense? Okay. So angiotensin 2 causes vasoconstriction. Total peripheral resistance will increase. Okay. It also causes release of noradrenaline at the sympathetic nerve endings, again increasing TPR. It acts on hypothalamus, causes the release of vasopressin, again increases TPR. Also causes increased reabsorption of water from the kidney. It also stimulates the thirst center, and the person will drink more water, again increasing the blood volume. And It will cause release of aldosterone, which will cause increased reabsorption of sodium and water from the kidney, again increasing blood volume and blood pressure. So you can see the multiple effects of angiotensin 2 to bring the blood pressure back to normal. Okay, so this is a very full system: renin, angiotensin, aldosterone axis. And because of this, in people who have hypertension, there are many drugs which target actually members of this pathway. Many drugs available. You may have heard of ACE inhibitors that inhibit that enzyme which converts angiotensin 1 to angiotensin 2. There are angiotensin receptor blockers which will block the angiotensin 2 receptor and it can't act. Okay, so there are many drugs which are available now. Okay, so blood volume increased, blood pressure increased. Now from hypothalamus, I showed you in the previous slide that one of the effects of angiotensin 2 is release of vasopressin. This is also called ADH. Yeah. This vasopressin or ADH, what does it do? It causes generalized vasoconstriction. Okay. And it causes renal reabsorption of water. Again, TPR will increase, blood volume increases, cardiac output increases, and blood pressure goes back to normal. Increases, yeah. So in summary, blood pressure is regulated by short-term and long-term regulatory mechanisms. Short-term is baroreceptor reflex, the main one. Medium-term and long-term are hormones, mainly the renin, angiotensin, aldosterone axis, plus vasopressin or ADH. Okay, and there's a complex interplay between all these factors, as we saw. So they help each other. Yeah. Now, what are the factors that affect blood flow? We have talked about blood pressure. Let's look at blood flow. In addition to maintaining a pressure, you need to maintain good flow through all the tissues in the body so that they get enough oxygen. Yeah. So what determines blood flow? Velocity, speed with which the blood is flowing. Yeah. Laminar versus turbulent flow. I'll explain this later. And the vascular compliance. Now, if you look at this, this is a cross section of a blood vessel, and the blood is flowing inside. Whenever there is, so blood vessel is similar to a tube or a pipe. So imagine water is flowing in a pipe. Yeah. Whenever a liquid is flowing through a tubular structure, it forms layers. These are called laminar layers, laminar flow. Okay. In the blood, it's not just water, right? It has cells, it has proteins, and it has certain viscosity. Okay. So certain components of the blood will be in the outer laminar. Certain would be in the different layers when the blood is flowing through the blood vessels. This is the normal flow, which is laminar. If somehow this blood vessel becomes narrow suddenly, now the components which were traveling in the middle can still travel, right? But those which were traveling next to the vessel wall, now the wall has become narrower. So they have to merge into the lamina which were in the middle. Does that make sense? So there will be turbulence. This is known as turbulent flow. And this turbulent flow is actually what creates sounds. Heart sounds. When the valves close, the blood flow becomes turbulent. That's why you hear the sounds, even over the arteries. When you're measuring blood pressure, the sounds that you hear are because of turbulent flow. And I'll explain that in the next few slides. Okay. Again, putting it in a simple form. So you have different layers in which the blood is flowing. So this is a normal laminar flow. Okay. Also called streamline flow. So what happens when there is laminar flow, the layer which is in the middle will be traveling slightly faster than the layers which are outside, because these layers are coming in contact with the vessel wall. There's some friction there, right? So in laminar flow, different layers will have slightly different velocity. Does that make sense? Okay. Now imagine this is a blood vessel and there is laminar flow through it. And there is a narrowing now. Here it becomes narrow. Okay. So you will have disturbance of laminar flow over here. Okay. The cross-section area is narrower. It will cause disturbance in the flow. Same amount of blood is passing through this narrow area, so the velocity will increase. And as soon as it comes out of the narrow part, again back to the normal size, okay, after a while, again laminar flow will be established. But at the narrowing, there is increased velocity, and soon after the narrowing, there is turbulence. So turbulence and increased velocity, then it will again become normal, laminar flow. Okay. So yeah, when there is turbulent flow, this is what creates sounds. Now, how many of you have taken blood pressure on a patient or a person? Yeah. So what do? You apply a cuff over their upper arm, yeah, and you put pressure. You put pressure to the limit that you collapse their arteries. There's no blood flow in the arteries, in the brachial artery. Yeah. So brachial artery is actually totally closed, right? Then you gradually start releasing the pressure. Okay. So the brachial artery, you actually close it, right? There's blood waiting to just push through, but you've closed the artery. Then you allow the artery to gradually open up again, and the blood will start flowing. When it starts flowing, when it passes through the narrow area and then it goes through, it will have turbulent flow, which will create the sounds. This is what you hear when you put stethoscope, right? Measuring blood pressure, this is what you hear. These are known as Korsakoff sounds, right? Korsakoff sounds. These are due to the turbulent flow that you have there, right? And when do they appear and when they disappear, it will depend upon that person's diastolic and systolic pressure, so you can have an idea what is the pressure in that patient that you're examining. Make sense? Okay. Before I go to the last topic, which is fetal circulation, any questions about the blood pressure, blood flow, and these factors that I just described? Now, another issue with this, which we will discuss later, when you have narrowing like this, okay, there are more chances of formation of thrombus over here, because in your blood you have clotting factors that can form a clot whenever there is an injury to blood vessel. But if there is narrowing of blood vessel, when you have turbulent blood flow, this can also make the person prone to develop thrombosis over there, to form an abnormal clot inside the blood vessel. And we'll talk about thrombosis as well next week. A lot of things to talk about next week. All right, very interesting topic actually. Any questions from online students before I move on to next topic? All good? Is there anyone there? There are, okay. They are there, okay. Quietly listening. Okay, all right, perfect. So let's move on. Fetal circulation. Now, this is a very interesting topic, all right. A fetus is not breathing through the lungs, right? So where the fetus gets its oxygen from the placenta through umbilical cord, and this is where CO2 and waste products and all those things, the exchange will occur through umbilical cord, placenta. Yeah, okay. So there must be some special arrangements in the fetus. And after birth, the umbilical cord is cut. So you have to immediately make changes. So lungs take over, right? So I'm just going to explain those few features of fetal circulation and what changes occur soon after birth, okay? Now, this is what fetal circulation looks like. There is blood flow through the lungs, yeah, but there is no exchange occurring, so very little blood flow. But the blood flow is actually through the umbilical vein and the umbilical artery. Now again, similar to pulmonary circulation, the vein is in red color, the artery is in blue color. Yeah, so the vein is having oxygenated blood, and the artery is having the deoxygenated blood, similar to pulmonary circulation. Remember that. Yeah. Now, the blood that enters, oxygenated blood, okay, then it goes here, and it enters the right atrium. In adult, where does the oxygenated blood come to? Left atrium. Remember, in adults, right, from the lungs, oxygenated blood comes to left atrium. Here, oxygenated blood is going to right atrium, and it's getting mixed with the venous return. The venous return that is coming also comes to right atrium. Oxygenated blood is also coming to the right atrium, right? So it's a very peculiar situation here. There are three special arrangements, or we could call them shortcuts, short circuiting. There are three short circuiting there, right? Because both arterial venous blood are mixing together, so you have to have some connections where you can supply enough oxygen to the body tissues and ultimately send deoxygenated blood back to the placenta. Okay, now let me explain this in a schematic. So this is in normal circulation, okay, in newborns or in adults. So you have heart here, yeah, you have lungs, pulmonary circulation, systemic circulation, right? We've already covered this. So what is happening? The blood is coming to left atrium, oxygenated blood, goes to left ventricle, goes to all the cells in the body, comes back into right atrium, goes to right ventricle, goes to the lungs, gets oxygenated, comes back to left atrium. Everyone agrees with this, right? What is happening in the fetus now? In the fetus, so the lungs are non-functional, okay? But the lungs are here. Placenta are the lungs, all right? And the kidney, right? So placenta is lungs and kidney. So you're getting oxygen and carbon dioxide from here, all the waste materials, everything there. I just put oxygen and CO2 here. Now, this was the normal circulation, right? But what's happening in the case of fetus, blood is coming and going into the right atrium. And then you have a hole between the two atria. This is called foramen ovale, a hole between the two atria. So this blood, which comes back, in addition to going into right atrium, it also goes into left atrium through this defect in the atrial, interatrial septum. There's a defect. So blood goes into the right atrium, sorry, the left atrium. Okay, from there, it will go to left ventricle, and then it will go to the peripheral circulation. Now, and there is, so this is known as, now oxygenated blood goes to left atrium, right? But it also goes from right atrium to right ventricle. We don't want to waste this oxygen. So we also have a shortcut, a short circuit, where this will also go to supply the peripheral cells with oxygen. Okay, so you have three abnormal connections here. Which ones? So this one, which is called foramen ovale, and this one. So the output channel of right ventricle meets the output channel of left ventricle. This is called ductus arteriosus. And then they have an abnormal connection over here. This is known as ductus venosus. After childbirth, after the child is born, this connection has to go, right? This one has to go, and also this one has to go. So this happens within the first few minutes to a couple of hours after birth, that these channels get closed. This one remains patent for a little while. There is some mixing of blood in the atria, but that is not a big issue, and closes in few days' time. Okay, and the lungs, the circulation through lungs becomes more, the circulation becomes more, and lungs take over. Okay, so this is what happens in in an infant. If I show you the actual location of these, so this is a schematic to give you an idea. If I show you actual locations of these three, so if I go back to that picture, there I showed you the fetal circulation, you can see where they are actually. So, come on. Okay, so you see there is a defect between the two atria, and the arrow shows blood is flowing through. So this is, what is this? Foramen ovale. Okay, now this is pulmonary artery, yeah, and this one is aorta. Between pulmonary artery and aorta, there is a connection. This is ductus arteriosus. Ductus arteriosus. So output channel of left ventricle and right ventricle communicate to each other through ductus arteriosus. Okay, and where is the ductus venosus? Where is it? Yeah, this one. Okay, this one. All right, so inferior vena cava and the hepatic artery between these two. So all these will have to close after birth, and this is what happens. Okay, so this is about fetal circulation and the changes that occur after birth. Okay, so the foramen ovale, ductus arteriosus, ductus venosus need to close immediately, yeah, because the umbilical cord is cut and the fetus has to start breathing, the child has to start breathing through lungs. Okay, make sense? All right, I think that's all for today.